So this talk is probably going to be a bit different than most of the others. So I think it was Andrew, one of the first talks, who sort of gave us a little overview of the field, I guess, different fields, statistics versus mathematical modeling and dynamical systems, I guess, versus the data side. And so I sit more on the opposite end. In the mathematical modeling, I tend to spend more of my time and interest in looking at the mathematical models and not enough time, I suppose, looking at the data. So this talk I'll show a little bit of the data, but it'll be a bit different than the others. So let me get the right window there. There we go. So I'll just go over a little bit about this COVID, the SARS coronavirus transmission, what we know, what we still don't know a little bit. Some of that's been mentioned already. And in fact, I think most of the models I'm going to talk about and things have been mentioned in a lot of detail already. So I'll just go over some details and try and focus in on the small community aspect as I see it. And to be honest, I'm not sure I have a whole lot of results at the end to share, more just questions, which may be appropriate for the last talk of the session and the conference. We'll see. So what do we know about this coronavirus? It's communicable respiratory infection, so it's spread person to person. It's not entirely clear still the importance of aerosols versus droplets versus surfaces. It probably depends on situation a bit, but there still seems to be, as we keep getting more information, seems to be switching back and forth on how important each little aspect is. Is it strictly close contacts? Can it linger around on surfaces for a while and spread that way? And there's still a lot of uncertainty on that, which pathways are most important. And also the correlation between symptoms and transmission still seems to be a bit unclear. Certainly if you look at the viral counts in respiratory attacks of people, symptomatic versus asymptomatic, there don't seem to be, well, I guess there's evidence that there can be just as much virus in respiratory tracts of people, regardless of whether they're showing symptoms or not. So if you think about an infected person as basically a walking virus factory that puts out virus every time they breathe or cough, stands to reason that the amount of virus being transmitted would be independent of symptoms. But then again, you get, there doesn't seem to be, well, I guess this is a lack of evidence rather than an evidence of lack case, but you get these gatherings, particularly of young adults. There's not an obvious spike in cases after those, at least hard to show, which doesn't really mean too much, I suppose, in the end, because there are a lot of cases going on to begin with, and you could have quite an effect of a short gathering without seeing a spike, but still. So we're waiting on, I think we're still waiting on data from reopening of schools in places where the schools never closed, just to see if we can figure out how important asymptomatic transmission is. And this gets complicated too. I'll mention this a bit later on too, when I talk about the models. It's not really a asymptomatic versus symptomatic transmission as much as mild symptoms and severe symptoms, and of course the behavioral part of admitting you have symptoms. This coronavirus presumably started spreading in New Brunswick in the middle of influenza season. Everybody has symptoms. So it's not unusual to have symptoms, and you have a mild infection of influenza or a cold or something. You don't necessarily get too concerned about it. And so now I guess people are more aware, and maybe we'll start to see more of a correlation between symptoms and transmission. I don't know, we'll wait and see. But certainly it's a respiratory infection, should be transmitted by close contact. Time in close contact should matter. Indoor versus outdoor should matter. And interestingly, so we've seen, at least in Canada, well, actually, no, I guess this is global, super spreading events, I suppose, in meat processing plants, right? So one of the, there are actually several hypotheses for that. One is that the people who work in these plants tend to also live in the same area. And so you're not just in close proximity in the plant, you're in close proximity at home. There's carpooling, but also interestingly enough, the hypothesis I thought was interesting was the cooler temperatures in the plants may facilitate transmission by prolonging the survival of the virus on surfaces, right? And so these are all just, well, I think this main point of this slide is just that there's still a lot we don't know. And so one of the pieces, so I'm in New Brunswick here, I'm interested in really spread in small, lower density areas, and the role of closing borders, whether it's a good idea, bad idea, what difference it makes. And as I said, I don't really have any answers to anything yet, but lots of questions. But certainly in the smaller communities, we don't have the steady number of background cases from little outbreaks everywhere. But we do have these super spreading events, right? So there's a question of whether certain people can be super spreaders. We heard, yes, it was an earlier talk this week, Typhoid Mary mentioned, which is probably a good example. And so one question I guess I raise with that is it a person who is a super spreader, or the workplace or the setting that is a super spreading environment? And sometimes that's a bit hard to tell, and certainly is disease dependent. But in the with this new coronavirus, it seems to be that I suspect it's a super spreading either event or environment more than an individual, right? Which is something I want to keep in mind with the models. The other point that we know is it's probably varies a little bit place to place, but overall North America, I think it's probably safe to assume that at least 95% of the population is still susceptible, which I guess always makes me wonder when I hear talks about first wave and a second wave. We haven't really had a first wave yet. 5% of the population infected is probably not really enough to change the dynamics once you get things back under control. We've really more just completely suppressed any first wave, even though, 5% is still pretty big, but the second wave could really still just be a massive outbreak, right? And it could happen as soon as things are relaxed, right? We'll see. But certainly the perspective from the modeling here, I guess, is that pretty much the entire population presumably is still susceptible. And again, that seems to vary place to place. New York, I think the numbers were possibly 20%, if I remember right, of the population infected, which seems consistent with mortality rates. So it's probably not an unrealistic estimate, I guess. And so, yeah, places like that, they've changed things enough that the dynamics will be different. Of course, now the other part is, even with any opening up of the economy, the behavior of people has changed, right? And so the dynamics of going into the summer and into the fall will be different because the overall behavior of the population has changed. Yeah, and then there's this is the big question, I guess, is there any immunity post-recovery and cross-immunity with other coronaviruses? And I don't think, I mean, we've got some successful vaccine, seemingly successful vaccine, what's the best wording there, potentially successful vaccines, but it's still early. But there's reason to be optimistic, I suppose. But there's still a lot of question of whether, how long any kind of immunity will last after infection, right? And the other, I suppose, obvious thing we know about this is that physical distance has actually been very effective at curbing transmission. It does seem to be an infection that is, the spread is controllable, admittedly with extreme measures, but still controllable, so it's good. And yeah, some caveats. So most infections recover with no or mild symptoms. Of course, most is probably maybe from the perspective of an asymptotics person. I grew up thinking that, you know, 1/4 was small, 1/10 was negligible. So most people recover with mild or no symptoms. Of course, you know, a small fraction of 10 billion people is still lots and lots of people. So small is relative, I suppose. So the recovery with mild or no symptoms, I'll come back to later on as well. Yeah, so to get to the small population bit, and now I get to experiment with my, I think I've shared my screen and not the window, so I should be able to do this. So New Brunswick in Canada, population of the province is 800,000 people, about 10 people per square kilometer. I think that was just under 30 people per square mile, so not very dense. Our largest city is Moncton with a population of 80,000. There are 3 other cities with populations not too much smaller than that. Still, even Moncton, the urban density is only 1,000 people per square kilometer, so fairly low density, right? There certainly seems to be evidence that the size of the outbreaks per capita, I guess, are larger in cities with larger densities. And so density does seem to matter. It makes sense. I think we only have 1 real elevator in Fredericton, in the city I'm in. There's not a lot of people going through. Probably not, you know, when classes open up, classes are still probably just as big, but the campus doesn't have as many people on campus, so the densities are just lower. The potential for spread of a respiratory infection is presumably lower. And now this is going to be probably the only data I actually have, and I'll maybe explain a bit why I've been slow to get into actually using data in the models, and I tend to always have more interest in the models than the data, which is probably a bad thing I need to fix. Now, I have forgotten how to get my pointer. Well, maybe the mouse will work. So this first part, this is back in early April. So March, I think New Brunswick had a couple of lucky things. One is that our spring break was a little bit earlier than in other places. The timing was quite nice. We seemed to get our first noticed cases somewhat just timed with the spring break, so that a lot of the closures of schools, in particular, the schools didn't let people who had been traveling on spring break back in, and the university shut down classes shortly after. So the timing was kind of lucky. We ended up just getting a small spike here. I think the peak is 15 cases per day, nice and small, total of 150 some odd cases right now. And, you know, rather short-lived and concentrated in 2 main centers, I believe. And so, yes, really a small outbreak, this first outbreak. This first outbreak here is, of course, a bit problematic because we're looking at cases, cases that have been identified through testing, And of course, this is the stage where the testing is only done on people who have been traveling and are showing symptoms. And so from what we know now, this is probably only a fraction of the actual cases. And it's not until recently that we've kind of got the resources in place, I guess, to do more extensive testing. And so this second outbreak here is quite a bit different. And I'll show you the map in a minute, but this first outbreak seemed to be centered on focusing on testing travelers and people with symptoms, only a couple of symptoms, the first symptoms that were noticed early on. This second outbreak is probably more a thorough testing of a community. This second little outbreak here is all in one community of about 9,000 people, sparked by presumably one person, one traveler who was infected and wasn't showing symptoms. And of course, there's a connection to a hospital and a long-term care facility. So we see the big spike here on, that should be just a few days ago, I think, where we had the 9 cases. Those are all 9 cases. Most of these cases were in one long-term care facility or connected with that care facility. So it hasn't really spread out into the community. So, and this is a case where now we've had either 25 or close to 30 now cases associated with that outbreak. And I believe we're doing something like 2,000 tests per day in a community of about 9,000 people. And so it's probably quite a bit safer anyway to suppose that this is a more accurate picture of who actually is infected, right? Regardless of whether they have symptoms or not. So the data here, we're looking at a very different thing than the data here, right? Unfortunately, I don't think I will ever be able to really get a hold of the details of that data, just because of the nature of what's going on with the outbreak. And the fact that it's New Brunswick's first mortality, and there's going to be some odds and ends. So I think hopefully everyone can see this map now. So I just wanted to sort of give you a picture of, I guess, the situation that we need to model in an area like New Brunswick. And so, yeah, since I'm sharing my screen, I'm hoping everybody can see the map and not the slide still, and see my mouse. So this is Fredericton, where I'm sitting right here. This is pretty much our road, not a massive road network. The main cities are probably Fredericton here, St. John, Moncton, Miramichi, bit smaller, but not too far behind. So the outbreak earlier on was mainly noticed in Fredericton and Moncton, I believe, and in St. John. And somewhere here, there's Maine, Baxter State Park. If we just scoot over a bit, Quebec City, and what really matters, I'm tracking my son, oops. He's sitting in Montreal, where there is a substantial number of cases, I guess, right? And so it is kind of a nice spatial aspect, even though I won't talk about that because we haven't really gotten sorted out on the modeling of this yet. There's a nice road from Montreal where there is a million people as opposed to Fredericton and Moncton with their 80,000 people. A nice road through Quebec City with another 300,000 or so people, I believe. And then we cross the border into New Brunswick, somewhere in here. And then we hit some centers, Edmundston, and it's fairly sparsely settled along here, this boundary with Maine here. The road and the river just follow that down until we get to the major centers by New Brunswick standards, Fredericton with its 50 or so thousand people, Moncton with its 80 or so thousand, and then we wander down into Halifax area, right? So it is interesting that with the air travel fairly limited, we really do have a nice one-dimensional spatial problem for disease spread in there that we're starting to look at, but haven't really gotten anything presentable on there yet. Interestingly enough, I wonder if I can zoom in here, the current outbreak is in Campbellton, little city here with 9,000 people. And right down the middle of this blue, which is St. Lawrence coming out? My geography is bad. No, it's not St. Lawrence. That's the Beta Chaleur, I suppose. I don't know what that is. Yeah. But the Quebec border is running right up here. And so effectively the border cuts this town in half, right? Pointe-à-la-Croix and Campbellton really are one community. And so it is a, you know, the border closing here is still fairly porous, right? Except that there's a lot of people that do move back and forth every day, but I believe I think the news reports, whether they are accurate or not, are that the initial infection was likely seeded from Montreal here, travel to Montreal. But it is, of course, not entirely clear, the history of things. Yeah, and so, yeah, so we have an outbreak in a town, and then spatially, there's certainly been, I mean, this is not a huge region, so we've closed borders between Quebec, right, which means really this road here, this little community here, and with Maine, so a few places along here where you can cross, and of course the air travel, but they're still fairly porous. But really the issue underlying this is it's not clear to me why the border between the provinces should be the real relevant thing when we have a city of 1 million people here and this whole area, a very low density population, right? So it's an issue of the larger centers connected to the low densities. Anyway, back to where I was going here. Aha, there we are. Yeah, and of course, yeah, in my usual situation with talks, I get a little sidetracked with the maps and things and introduction, and of course, I probably have to skim through things really fast, but that's okay. So I thought one of the pieces I thought would be useful to go into, given the focus and nature of some of the other talks, has been a few things mentioned that made me think that this would be useful. And okay, and yeah, and with 74 people still attending, this is very unusual for the last talk in a workshop. Usually people are sitting with their bags packed, suitcases in the back of the room. Some people have left already. Yeah, this is very different online, where, well, I guess everybody's eager to get to lunch, but yeah, nobody's got to take a flight home. Nobody's had 4 days of, well, this would be Fields Institute, right? So one thing we're missing is 4 days of all those really good cookies and lots of coffee and nice lunches. Well, so yeah, very different. In any case, the usual epidemic model, this is not really the first epidemic model, but it's the first one I always think of as the first one. It's the integral variation of the Kermack-McKendrick model. And I like it, looking at this, essentially, it's the age-structured, disease age-structured model. S is the number of people who are susceptible. X is the incidence, the number of new cases per day, new infections per day. And so you track those people by look back through infection age. So A would be a looking back in time to today minus however many days, and looking at beta of A would be the force of infection or infectivity, infectiousness of a person who was infected initially A days ago, right? And then P is the probability of that person still being infectious or alive or possibly still active in transmission. Not quarantined, not isolated, not moved somewhere else, right? And so there's a lot of stuff buried in this beta, basically all the stuff about the disease transmission, the contacts, the behavior, but I do like the formulation of that, and that's basically the formulation that's been all of the infectious disease models we've seen, I think, kind of have this formulation buried in them, right? Just lots of different perspectives on the same thing. And so one thing we can look at, total number of people infected, would just be integrating over the probability distribution P, which is the probability of still being infectious at age A. So having not recovered or died or gone into isolation, I suppose, if you like. And the force of infection would be integrating over both those things. And so I think, yeah, skip that. And so this is a, so I mentioned that there's still a lot unknown about the connection between symptoms and transmissibility. But we do seem to know for this coronavirus that the amount of virus that you're shedding seems to be somewhat independent of symptoms. Now there's a lot of caveats to that, but it does seem to be the case. But then there's the connection between virus you're shedding and how transmissible it is, which, you know, symptoms include coughing, sneezing. It's reasonable to think that there might be more virus transmitted there, right? This is for influenza. I don't think, I haven't seen any comparable data, and it would be nice to see for this coronavirus. But for influenza, there's a bit of about a 1 day gap here, right? The peak of the shedding of the virus peaks before the peak of the symptoms, right? So you have a bit of pre-symptomatic transmission, right? And so this is essentially what I look at to say this black curve here should be, or the black dots should be, what I've called beta, the transmissibility. Something that starts out low. There's a bit of a lag while the virus sneaks past the immune system, builds up in the lungs, and then the virus shedding starts and decays off oddly linearly. And so, of course, with the, oh, no, not quite yet. So with the deterministic models of this form, there's basically two results, a threshold condition and a final size. For the most of what we've seen, I haven't seen too much of this reproduction number mentioned, probably because when you get the complicated spatial considerations, it just doesn't seem to be as easy to pin down or as useful, I think. There's too much heterogeneity to make much use of this reproduction number, which is averaged over, excuse me, averaged over the whole population, all kinds of different settings, contact rates. But there is a lot of mention of the final size, right? And so one of the points I just wanted to make quick was that the final size is kind of just a property of these types of models. And it's also one of the things I think I wanted to look at, right? So there's a final size relation. And so I will skip that bit. And this is somewhat useful. I was going to do a digression about masks, but I think I will skip that. there is this threshold as you increase this parameter R naught, basically increasing the average infectiousness over the whole population, over your whole network or geographic region. There is a threshold where you get outbreaks, small outbreaks or large outbreaks. So in the deterministic model, this would be a threshold for exponentially decaying solutions following an introduction or exponentially growing, right? And so we've seen a fair bit of these types of models here. So I will, this figure, this is just a solution to the simple SIR epidemic model. So just to imagine, well, it's probably worth just reviewing just a little bit because I don't know the background of everyone in the audience. And we got 100 people or so. But this is the classic trajectory for an epidemic. You start off with an introduction of an infected individual into a population that has S0 people who are susceptible. The infection keeps going until essentially enough of your contacts by an infected person are wasted on other infected people. And then the disease decays, and then there's this final size. Of course, if your susceptible population is below this threshold, you just get little blips here, right? I didn't draw any on, but you get little blips of solutions. The case we're looking at is over most of the world is probably epidemics that are fairly well controlled because of community quarantine efforts, social distancing. And so you get lots and lots of introductions followed by little outbreaks that gradually reduce your susceptible population, right? So we do see the flatten the curve, the first wave, second wave, but it is, I think, also important to remember, and I think we've seen some of the endemic, epidemic versus endemic, although this is a little bit different. Unless your infection is eliminated globally, you will still see importations and small outbreaks, which means that the final state is effectively that pretty much everybody will be infected. All our control measures, or what we're hoping to do with the control measures, is not to eliminate, but to delay hospitalizations, basically, right? And so that's just one thing to keep in mind with that one. So now I will, try to wrap things up a bit with the models. So we've seen the SEIR model, and really what I wanted to get to and emphasize here, yeah, I think our last talk, actually it's been a few talks with descriptions of SEIR models, so I can skip through that a bit, other than to note that the if your susceptible population is large, then even now with what are seemingly, you know, they seem like fairly large outbreaks, 100,000 people infected in North America is big, right? But it doesn't decrease the pool of susceptibles that much. There has been just a small change in this S0, 5% drop maybe over most of North America, maybe a 20% drop in some spots. So we're still kind of in a safe to assume that things are linear, right? Which is nice. And so a lot of what I'm going to say here is focused on breaking this up into the transmission pieces on this graph and the progression through the infection, right? And so this was something we did back for influenza, which is also a contagious respiratory disease. So Sorry, I promised to watch the chat window and I only just noticed that there was a question. Oh, that's why, because it's only just popped up. So yeah, a question about whether beta is function of time and not constant. Yes. And I think, yes, actually, I think that actually leads in to this next piece. So for influenza, the one thing that popped up in that last influenza pandemic was the importance of asymptomatics, just like it is now, right? And so the simple model, we just split the infected compartment into two. But it is basically just the SEIR model, right? Just tracking symptomatic and asymptomatic infections, right? And so your transmissions, which are the same transmissions we use in the stochastic models, which are, and the infection rates are basically the graph is translated into these two matrices. The inverse of this transmission matrix is the times spent in each compartment based on a certain case. And so it basically turns out that for the deterministic ODE model of this format, you take the exponential of this matrix and whack it with the appropriate left and right vectors to pick out the terms corresponding to the infection and the beta that's constructed here. And this curve here will be your, what I've called the beta of not time, but of age, right? Time since infection. Effectively in the ODE model, you're thinking of it following a cohort of individuals infected at time 0 and follow them through. And this would be the fraction of the cohort who are infectious at age T since infection and multiplied by the force of infection transmission rate, right? So this is what we're trying to match to the viral loads, right? Or what we think is the infectivity. And so for, there's two things that are going on with this coronavirus. Well, actually three things now that I see this other question there. One is that we seem to have a bit of a longer pre-symptomatic stage. And the other one is we have fairly even asymptomatic. So one thing you can do with this, and this is probably not new to most people, it's certainly not a new thing, you break this up into stages and you can stretch out this distribution, right, to make it match what you want. Actually, most of the talks seem to just go straight into other distributions. So this is more really just a connection to the differential equations and the some of the other things we've seen, right? And so this blue one is for this model here compared to the red one that was for the other model. I think on the blue one, I just assumed that the asymptomatics were doing all the transmissions for reasons I will explain. With this one, I think this is the model I like to play around with for the coronavirus. We have definitely a pre-symptomatic or an incubation time, right? Distribution of incubation times. And then the possibility of pre-symptomatic and asymptomatic transmission. But one thing I wanted to emphasize, and what's going on here, these phi's would represent progression to symptoms. And what's buried in phi is really immune system responses, right? Questions about how quickly you manifest symptoms, but also a lot of behavior, especially earlier on in the first part of the epidemic, which hit right in the middle of flu season. This progression from asymptomatic to symptomatic is not really based on symptoms, it's based on recognition or realization or admission that those symptoms are something to be concerned about, right? And for a lot of early on in the epidemic, I suspect people with symptoms didn't change their behavior just because it's the middle of flu season. You've got flus and colds, and a few sniffles or coughs aren't going to slow you down too much, right? It's not till you hit later on with the fatigue and whatnot. So yeah, so this is the model I wanted to play with. So what I will show you quickly, and yes, to answer Lisa's question, time dependence probably also hits in here, right? Behaviors change. Later on in the epidemic now, where people are more aware of what's going on, these rates will be very different because people will be presenting, isolating themselves, going and getting tested, more easily on fewer symptoms, right? Yeah, and so just quickly then to wrap up, so if you run the stochastic versions of these models, this is just taking these rates, stuffing them into a Gillespie algorithm. One of the interesting things you see, which is connected to what we want to use for warnings, metrics on when to respond, as I increase R naught, in this case by changing these diagnosis rates or testing rates or rates of symptom development, how quickly people switch into realizing that they're infectious. You do see, I guess it's a reversal. As I go up, as I go down, people are isolating themselves more likely, right? So your reproduction number is falling. So as we relax restrictions, also we will see this creep up here to not necessarily bigger outbreaks, because you do get all these little, the stochastic models give you all these little outbreaks, but fewer failed outbreaks, which of course we don't see, so we don't know anything about, right? And then more of your small outbreaks become large ones, right? And so I think I might, I was going to talk about the network and the spatial, but then this is the same thing with a network model with different structure changing the susceptibility. What I'd really like to do is to figure out what you can use for metrics. And really all you're seeing are these, this is the final size of an outbreak, small outbreaks lasting a few days, weeks, after you've done all the testing and collected all the cases. Where are we sitting there? And so I think I will, yeah, just wrap it up there. In closing, we still need to know more about what constitutes contact and what heterogeneities in those contacts are important by location. And we still need to know a lot more about progression from infection to disease, because what we're seeing is not infection, but the symptoms and disease, right? Okay, so thank you.